You're about to experience Healthline, a show where doctors from 𝗏𝗏𝗵𝗹 interact with you for a healthy, uplifting lifestyle. Moderated by Nicole Jacinto. You've got questions, we've got answers. So welcome to Healthline.
Hi, everybody, and welcome to Healthline with 𝗏𝗏𝗵𝗹. Indeed, you've got questions and we've got answers. One of your questions may be, why is she in her car? Well, let me answer that very quickly before we start our show. Our topic for today is stereotactic radiosurgery, and our guest, who I'm going to introduce to you in just a bit, is Dr. 𝗏𝗏𝗵𝗹𝗁. I'm in my car because we are experiencing what we call in the Philippines as brownouts, and they call it blackouts in other areas. It's just intermittent loss of electricity. But you know, when you lose the electricity, you kind of lose the Wi-Fi connection as well. So I didn't want to risk that for all of you today, and that's why I'm in my car. Don't you wish we had more, we had better antitrust laws and that they were actually implemented so that, we could choose our providers and that we had better providers. But anyway, let's get back to today's show and today's topic, and let's meet Dr. 𝗏𝗏𝗵𝗹𝗁. Hello, good afternoon, doctor.
Hello, hi, good afternoon. Hi, Nicole.
Hello, you're more handsome than you are in the picture that I saw of you. So
no, I still had hair then.
Well, with or without hair, you're very handsome. You are actually more handsome than in the picture that I saw of you. So welcome to the show.
Thank you.
Today, I'm going to read a bit from my phone and my notebook here. I never, really lose my notebook and paper. But Dr. 𝗏𝗏𝗵𝗹𝗁, you are a neurosurgeon. Am I correct?
Correct.
Okay.
Correct.
When we talk about neurosurgeons, that's specifically surgery for the brain or other areas?
Brain, spine, and peripheral nerves. Yes.
Okay. Brain, spine, and peripheral nerves. And you just do surgery, or you also see patients for other, like if they just have
usually I operate 90% of the time. I operate. Of course, there are certain conditions that can be treated. I mean, usually after surgery, say a brain tumor, still needs some treatment and follow-up. So that makes up the rest of my clinic time.
Okay, doctor.
Yes.
So thank you for sharing some of that precious time with us, and for sharing your information and knowledge here on Healthline with 𝗏𝗏𝗵𝗹𝗁. Okay, so doctor, my first question to you is, our topic is stereotactic radiosurgery. What exactly is it, if you can tell us?
Sounds Greek. Anyways, stereotactic radiosurgery, to make it as simple as possible. It is basically a technique wherein we can deliver a high dose of radiation to a very specific point in order to, literally to ablate it. So sunugin mo talaga yung tumor. Okay. The easiest way to the best analogy for it is actually, I don't know, when you're in elementary, do you remember using the magnifying glass?
Yes, for the
so when patients undergo radiotherapy, it's like going sunbathing. You go out, you expose yourself to the sun. Takes a while for you to get your tan, and then you go home, you rest, you get a tan again tomorrow. So basically, what stereotactic radiosurgery does is you get a magnifying glass and you concentrate that energy from the sun into one focal point. Wherein earlier you can have a tan. Now, if you concentrate that energy into one focal point, then you can get an actual burn. So that is the simplest analogy of what stereotactic radiosurgery does. It concentrates the radiation that is usually given at a lower dose. It concentrates it to a single focal point and burns whatever it needs to be treated, like vascular malformation or a tumor. Yes.
Okay, that's a great analogy, doctor. And I'm just reminding those other ones out there who maybe were not kids when we were kids. I don't know if they still go out there and they use magnifying glasses, no?
Yes.
So just like if when we were kids, one of the fascinating things that we would do was we get a magnifying glass and maybe put it on you could even start a fire sometimes if it was that hot, no? Put it in front of the, let's say an ant, actually, they would tell us, you can kill ants that way. So
Yeah.
if you put the magnifying glass there, all that heat from the sun gets concentrated and it burns that ant or burns that piece of paper or whatever. But
Yes. Correct.
but that is as you were saying, that's what stereotactic radiosurgery actually is, like concentrating it all on one point so that it burns right away.
Yes.
And you also compared it to getting a suntan, where like if you go out and you sit by whatever the pool, or you just go out into the into the fields or even the streets or the beach, and you want a tan on that day itself, it doesn't show up right away, right?
Correct.
Like it's like you go home and the next day and or 2 days later, you notice, hey, great, I got darker,
Yeah.
or you might have a sunburn in that case. But as you're saying, with stereotactic radiosurgery, it's like getting that burn right away. And
Yes.
doctor, you mentioned to treat things for stereotactic radiosurgery. Is it only the brain that you use it for? As the
No, actually, the applications of stereotactic radiosurgery has been. It started out with the brain, and now it's being used in the spine. Also, they use it for the liver. They also use it for the lung. Basically, anything that requires a high dose of radiation can be treated with this technique, stereotactic radiosurgery.
Okay, great. And then okay, it's not just the brain that it can treat. As you said, the spine or the liver, you can use stereotactic radio surgery to do that, no, to treat. And doctor, you mentioned some things earlier, no? What exactly do you use it for? Like, is it you mentioned tumors, and you said abnormalities in the cells. How about lesions, and what exactly are lesions? Like, if you can tell us some of the things that it's used to treat.
Okay, so usually we treat stereotactic radiosurgery with meningiomas or vestibular schwannomas. These are the tumors that respond quite well to stereotactic radiosurgery. Metastasis, so tumor that has spread into the brain, can be treated with stereotactic radiosurgery. Another thing that we treat is actually arteriovenous malformations. Arteriovenous malformations, congenital, like a clump of blood vessels in the brain, that these are lethal. No? They can bleed, and stereotactic radiosurgery can be used to obliterate these AVMs without the need for surgery. The nice thing about stereotactic radiosurgery is that it's an outpatient procedure, meaning you come here, we treat you, and you go home the same day. I always tell my patients that after the stereotactic radiosurgery, you can go straight to the mall, and there's no downtime. If you want to have your radiosurgery today and go back to work tomorrow, then you can do it. You can do that perfectly.
So this is stereotactic radiosurgery different. Sorry, go ahead, doctor. I didn't mean to interrupt you. Oh,
No,
you're saying
no, go ahead. Sorry.
it's
Yeah.
how is it?
No, go ahead, please.
I'm sorry. It's different from other neurosurgeries in the sense that you don't cut and you don't have to spend as much time in the
Correct.
hospital. It's an outpatient procedure. Okay, so you don't cut into the brain, let's say, or the spine.
Correct. It is.
Okay.
No. This is it's they say it's brain surgery with no incision. So firstly, we have to look at the patient and see if the lesion is something that is amenable to stereotactic radiosurgery. There are certain lesions that are amenable to stereotactic radiosurgery. Like I said, vestibular schwannomas, meningiomas, pituitary adenomas, vascular malformations. There are some tumors that are not amenable to this. So the first step is actually to see a neurosurgeon and see if your lesion will qualify, or stereotactic radiosurgery would be appropriate for the lesion. After that, if it is deemed appropriate, then the first step would be to do a high resolution imaging. Usually, we'll have an MRI that has 1 millimeter cuts. No, The usual MRI is around 5 millimeters. Here, it's a millimeter cut
So it's
because
very
basically this procedure is 1 millimeter. 1 millimeter
I
cut.
can't even do this with our Okay.
Yeah.
Eyes,
So
how about
we do
CT
1
scan?
millimeter cut for the brain. It's an MRI.
MRI, okay.
Yeah.
Right,
And then
so
from the data from the MRI,
that's where you can see what area you need to go to
yeah,
if a patient is a good candidate and if the whatever the abnormality or condition is can be treated. Okay. Well, back let's circle back to that a bit later, doctor. I'd like to ask you first, is this a new technique? I mean, how long has it been around? Is it cutting edge? How long has Makati Med had it? How long have you been doing it?
well, Makati Med was one of the first. We started stereotactic radiosurgery way back 1996.
Wow.
But the technique was actually invented in 1969, but it was eventually perfected in the 90s. And Makati Med was the first to acquire this technology. And we've been doing it since 1996. So yeah, that's more than 20 years that we've been doing this.
That's amazing because
We've treated thousands of patients already.
yeah, because we rarely hear of it. As like non-medical professionals, we rarely hear of stereotactic radiosurgery. And most of the time when we think of surgery, especially for things like tumors and when it comes to the brain or the spine or the liver, as you said, we automatically think that the surgeon will cut. Of course, that happens also, and there are good reasons for that. But we don't quite hear about non-invasive things as much. And as you said, Makati Med was the first one to offer this surgery. So another innovation by Makati Med. Okay, doctor, before we continue with our questions for this show and get to know you a little better as a neurosurgeon, of course, and this great thing that you do that has been around apparently since 1969, as you said, but the technique was perfected in the 90s. We're just going to take a short break and we'll be right back. So doctor, especially doctor, don't go away, and audience, certainly don't go away. We'll be back after just a couple of reminders.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
World-class quality healthcare with a heart is now more accessible and affordable with Makati Med Care Access. I am Dr. Jacinto from Makati Medical Center. Our mission is to serve and provide compassionate care and excellent service to everyone who needs it. And now, we are bringing our renowned brand of world-class healthcare to where you are. With Makati Med Care Access, we have expanded our services beyond the hospital premises to serve you in convenient locations where you can avail of premium but economical healthcare. The Makati Med Care Access Araneta City is where we offer health screening and diagnostic procedures. Here, you can get services such as mammogram, ultrasound, lab procedures, ECG, and many others. What's more, Makati Med Care Access Araneta City is the only single-use hemodialysis center in Araneta City. This makes it easier and convenient for patients to avail of renal care services right in the heart of Cubao. Here at 𝗛𝗶𝘵𝗵𝗲, another Makati Med Care Access Clinic is located, offering outpatient care like consultation and diagnostic procedures such as medical assistance, hospital admission assistance, blood pressure monitoring, laboratory tests, and X-ray, among others. This is really convenient for those residing in Makati and nearby communities who do not want to proceed to the hospital to have these treatments and procedures done. The Makati Med Wellness Center, located at Ayala North Exchange, is a warm and comfortable space where executive checkups and services for holistic patient care and wellness can be available. In this wellness center, we have a skin and laser hub, diagnostic imaging, health screening, mind and wellness care, and physical medicine and rehabilitation. It is equipped with modern facilities and has competent healthcare professionals who are committed to deliver premium, personalized, and easy access healthcare services to adult and pediatric patients alike. It is connected to the main hospital by a bridgeway at the side of Ayala North Exchange. To make our services more accessible to certain areas, the Makati Med Mobile Care Access was launched. As the name suggests, this service is mobile. We go to where you are. Mobile Care Access deploys a team of professionals for face-to-face consultations and to conduct basic laboratory and diagnostic procedures, as well as vaccination and testing, depending on what your community needs. We can go to any location of your choice within the metro and conveniently offer healthcare services to fit the needs of any community or group. For added convenience, different modes of payment are available, inclusive of HMO benefits for those with a valid letter of authorization. Now that is truly accessible healthcare. All these additional locations under Makati Med Care Access are meant to make it easier for more people to avail of our services. After all, access to affordable, quality, and compassionate healthcare is a basic human right, and we at Makati Med are doing our best to make this possible to more people. For your healthcare needs, please visit us at the following Makati Med Care Access Centers or contact us to come to you and allow us to take care of you.
You're back with Healthline, keeping you healthy. Moderated by Nicole Jacinto.
Okay, welcome back to Healthline with Makati Med. I'm your host, Nicole Jacinto. Today, we're talking about stereotactic radiosurgery. And our guest is Dr. Michael 𝗛𝗶𝗶. He is a neurosurgeon. We talked a little bit earlier about what exactly stereotactic surgery is, and many people will be happy to know that if they happen to be a candidate for this, Makati Med has been performing this type of surgery since 1996. It was the first in the Philippines. So, if you are a candidate for stereotactic surgery and you happen to have a condition or a disease or illness that can be treated this way, they don't cut into your brain or your spine or your liver. Dr. 𝗛𝗶𝗶 gave us some examples earlier about some of the areas or organs of the body that can be treated by this stereotactic radiosurgery. And as he said, they've treated thousands of patients. And also, as you heard on the reminders, Makati Med is doing its best to bring affordable healthcare and good healthcare to everyone. They have different areas in Metro Manila that you can go to for clinical procedures or tests. They even have vaccines, and you can call those numbers that you saw earlier, or simply go to the Makati Med website to learn more about how you can avail of their services, their mobile services. They can go to any area in Metro Manila. Okay, so Dr. 𝗛𝗶𝗶, earlier we were talking about the types of conditions and maybe illnesses or diseases that stereotactic radiosurgery can treat, or that you can use stereotactic radiosurgery to treat. You mentioned, apart from tumors and I think you said lesions, that there's a congenital condition with where the blood vessels are clumped in the brain, and you can use that to treat it, no? Okay, sorry, can you say that again, doctor? Doctor, can you say it again? What is it?
Arteriovenous malformation.
Okay, all right. How about when someone this is I know what's on many people's minds. What about if someone gets a stroke? what happens to that part of the brain? Is that something that you can use stereotactic radiosurgery to treat?
Okay. Unfortunately, strokes are not treated with stereotactic radiosurgery. If it so happened that your stroke is due to a ruptured arteriovenous malformation or AVM, then stereotactic radiosurgery would have a role. But most strokes, the hypertensive strokes, are not amenable or not treated with stereotactic radiosurgery.
Okay, thank you, doctor. Thank you for answering that question. And then, okay, so gave such a great analogy about, you know, how stereotactic radiosurgery works. Can you tell us some of the benefits, or all the benefits of stereotactic radiosurgery? Stereo reminds me of, well, you know, our old stereo systems, and then radio, of course, radio and the radiation. So anyway, how this type of surgery, the benefits of this type of surgery, especially maybe probably in contrast to other types of surgery.
Okay. So just, so for it not to be a tongue twister, just call it SRS. The nickname of the surgery is SRS. So, of course, the obvious advantage of stereotactic radiosurgery is that there is no incision. So, people who are scared of having open brain surgery, then some of their brain lesions can be treated this way. Secondly, there is no downtime. So since it's an outpatient procedure, like I said, you can come out of the hospital and go to the mall immediately, or ride the plane and go home if you're from out of town. There's no downtime. It's actually cheaper because if you have brain surgery, open brain surgery, you have to be confined in the hospital. You have to pay the doctors and everything. Here, it's actually a package. So the cost-wise is actually cheaper. But like I said, not all brain lesions can be treated with stereotactic radiosurgery. Another thing that, lesions that can be treated with radiosurgery are lesions that cannot be safely reached by surgery. Remember, our brain has a lot of structures that do not tolerate manipulation or actual surgery. So if the tumor is, say, situated in a place where it's very delicate, there are a lot of blood vessels, there are a lot of nerves beside it, or areas for wakefulness, or areas for moving half of the body, then we can do this procedure and definitely we'll be able to address the tumor, and there'll be less risk for the patient, or actually no risk to the patient.
Doctor, you mentioned parts of the brain where perhaps a lesion or tumor or some kind of abnormality that can be treated with stereotactic surgery could be. Would that be areas like, let's say, if there's a lot of brain tissue, as you said, there are parts of the brain that cannot tolerate a lot of manipulation, as you put it. Would that be like, let's say, in the middle of the brain, or like in the frontal lobe or something like that? Is that where you would use it if it could be treated by the surgery?
Well, throughout our brain, there are areas that should not be touched. So areas that are close to the visual apparatus for vision can be treated with stereotactic radiosurgery. Areas that are concerned with hearing can be treated with stereotactic radiosurgery. Areas that are related to movement, say, of our eyes or of speech, those are areas that do not tolerate manipulation quite well. So stereotactic radiosurgery is a definite option for these patients.
Yeah, that's good to hear. I mean, that's an option that you can take if the tumor or lesion or whatever abnormality it is that's there, or whatever condition you have wherein there is a physical thing in your brain that needs to be removed or treated. The stereotactic radiosurgery is an option, or can be an option. That way,
Okay.
there's less risk, of of rendering someone like maybe open surgery before it. I did you remember lobotomies? I mean, like they would just like kind of render people very helpless afterwards because some of those the parts of the brain that you said should never be touched ended up being touched. No. Um.
Um,
Go
can I, there's
Yes.
one thing that I have to clarify though. Um, Stereotactic radiosurgery is not surgery in in the true sense,
Mhm.
because surgery means taking out the lesion or taking out the tumor. Stereotactic radiosurgery, basically the exact term is to render the tumor biologically inactive. In short, it will just kill the tumor. The tumor will die, the tumor will shrink, but it will not disappear. So that is one thing that is one area of concern, because if the tumor is very big and it's causing a lot of pressure, then stereotactic radiosurgery might not be the best procedure for you, because even if we treat it with radiation, the tumor will still be there. Might shrink a bit, but it will still be there. That's why lesions that are good candidates for stereotactic radiosurgery, like I said, are small lesions at the base of the brain, lesions that, you know, we just stabilize them
Mhm.
and they don't grow, and then happy na tayo doon na wag lang silang lumaki.
Yes. So I'm glad that you clarified that, no, with the audience and with me, because with stereotactic radiosurgery you don't remove the tumor, it just kills it. So you don't bury the body, it's just there. Okay, you kill it and the body remains there. Maybe I've been watching too many of those mafia movies, but anyway, um you just render it, as you said, inactive or helpless, or the hope is that, or it can't affect you anymore. But as you mentioned, if the tumor is too big, the size itself can cause pressure in the brain. So even if you use stereotactic surgery to maybe stop its growth or render it innocuous, it's still it the fact that the size is big and is pressuring the other parts of the brain or vessels or what have you, that may still not be an option to get you well. Yeah.
So another role of stereotactic radiosurgery is to treat residual disease.
Mhm.
So let's say you have a big tumor, it's in a sensitive area of the brain. Let's say 90% of the tumor is in an area that is not sensitive, but only 10% of the tumor is in the sensitive area. So what we can do is we can take out 90%, that part of the brain, that part of the tumor that is safe to remove, and that 10% that will be left, the part that is very sensitive, can be treated with radiosurgery. So radiosurgery is also an adjunct to open surgery. So there are areas wherein we can't take out everything, then whatever is residual can be treated with radiosurgery.
That's great, doctor, and that's great to know. So you may use it, as you said, as an adjunct, where I'm just how I say this, recapping. Let's say there's a big part of the tumor is in an area where you can manipulate, or it's okay, it's pretty safe, and because of its size, you have to take that out. But then there's a part that remains in an area of the brain that you should not touch, as you said, you should never touch. Then you can use that the SRS. And is that true also with other parts of the body, like maybe the spine or the liver, as you mentioned? Like do you use it also as an adjunct for those?
Okay. As far as the spine is concerned, we usually use stereotactic radiosurgery for metastatic lesions in the spine. So metastasis means tumor or cancer from another part of the body that spreads to the spine. Normally, if we just radiate, the ordinary type of radiation, there are some tumors in the spine that do not respond to ordinary radiosurgery. So those patients, the patients whose tumors, like renal cell or renal cell cancer, It's a cancer from the kidneys that can spread to the spine. It is known to be not responsive to radiation. So if ever there is spread to the spine from a renal cell cancer, then it's a big surgery to take out that part of the spine and change it and replace it with metal. Stereotactic radiosurgery, because of its technique of being able to deliver the dose in one single, single shot, it actually makes these renal cell cancer metastasis to the spine, they are responsive to SRS. So that is one advantage of stereotactic radiosurgery, where lesions that used to be not amenable to radiation, because of this technique of single high dose, become susceptible to radiation.
Thank you, doctor. When we talk about radiation, I remember meeting a couple of people where they would have to go every day for a certain period, no, and kind of go under a sort of X-ray type of thing. Was I was never in the room when it happened, so I'd have no other way to really describe it, but they just described it to me, so I'm just trying to relate as best as I can. And they would receive radiation. So when it comes to like certain, like the particular cancer that you mentioned, the renal cell cancer, it's known to metastasize or kind of like spread to the spine. That's not responsive to the typical type of radiation where you have to get it every day for a certain period, or I don't know how many weeks, a few months, no. But with stereotactic radiosurgery, because it's one big bang, one high dose, like you described earlier, the magnifying glass immediately burning up the ant, or a small piece of paper, or starting a fire. You Boy Scouts, Girl Scouts, we cheat. We'll just use the magnifying glass instead of using the stones to cause a spark and a flint. So because of that one big dose, it is successful at treating that. So okay, so it's good to know that it's not just applicable to one thing, and it's not just used in one way. I'm talking about SRS, or stereotactical radiosurgery. As doctor here has told us, it can be used solely on the brain, or perhaps on the spine, or on the liver. A few areas he mentioned in the body.
Yeah.
Sorry.
Unfortunately, here we don't have the equipment yet for liver and lung, because the liver and the lungs are moving organs. So this needs a stable lesion like the one in the brain. When we treat patients in the brain or in the spine, there is actually a mask or a fixating device to keep the head perfectly still during the procedure. The procedure itself takes around 30 to 45 minutes. That's the actual time when the radiation is turned on. And during that time, that patient cannot move. Even with a millimeter, they cannot move. So they're usually made to, a mask is actually fitted so that they can't move their head.
Okay, so doctor, I mean, that's a really good point you're making. Like right now, we don't have the technology yet in the Philippines for using this SRS on organs like the liver or the lungs, because they move around. Even if you keep your body still, they're kind of
Keep breathing.
Keep breathing. So you can't stop that. Otherwise, you would be dead. You can't stop that. But for the brain, you can hold still, and you have to hold the body very still. So you said that patients usually wear a mask. Is this a mask that you make for the patient itself?
Yes.
Or
Yes.
herself?
Actually, the fixation device is dependent on three fixation. How will I say it? So basically, there's a mask to fix the head. There is also a nose bridge that stops that prevents movement of the head, and there is also a bite block. All these three combined, so they bite on it, and there's a thing that holds the nose and the mask. Because remember, this is very high dose radiation. It has to be millimeter accurate. So that is the way how we secure the head during this procedure. During the olden days, we actually put screws on the
Yeah.
head. There's
Yeah.
actually a head frame, and
Yeah.
that is the thing that secures the head. But nowadays there are newer fixation devices wherein we don't actually have to literally put screws into your head.
That,
No,
that's
no
that's
wound.
that's
So
great.
there's no wound. There's no wound. Back then, you go home with a
Yeah.
band-aid, 4 band-aids. But now there's nothing. Just the mask.
Back then, doctor, I mean, you'd really drill screws into a head. Like how deep? Just, out of curiosity.
It through the skin, and it will bite onto the skull.
Okay,
It's a
so
very
by
sharp screw.
okay, and just to really hold your head steady, and then
Yes.
is the patient required to close their eyes? Do you anesthetize them? I guess we're getting
There's
into
local anesthesia.
an
So there's an injection, but we don't do that anymore. Not in Makati Med. In 1996, I think by around the I think around 19 almost I think around 2015 we stopped doing that. We're using the mask.
yeah,
Yeah, we're using the mask system.
that's great, doctor. So I mean, fewer wounds, because before you really had to use those screws, because
Yes.
that to keep the head still. As you said, with stereotactic radiosurgery, you have to be very still because it has to be very precise. You said down to the millimeter, which I can't even do with my. If you are watching or viewing, you can see me trying to get a millimeter with pinching it, but it's not. I can't even do it. So it has to be very very precise and very because all that concentration, all that radiation has to be in that area itself. So you can't move your head, and that mask that you now make patients wear, which is fitted for them, no? It's
Correct.
custom
It is molded.
molded. It's three parts. One is the mask, one is for the like in the bridge of your nose, just keep it from moving, and one is what you bite down on.
Yeah, it's a bite block.
Yeah, bite block. Yeah, okay, bite
Yeah.
block. We do move, even if we don't want to. We may twitch, we may squirm, we involuntary movement. So that is your. At least now we have this mask, and our mouth can move, our jaw, and once it moves, there's a risk of not getting that radiation to the exact right spot. So this is really good that it's part of the one of the tools or equipment or part of the technique that you use in the surgery. And since we're talking about that, doc, what other when it comes to stereotactic surgery, what exactly do you use? You mentioned MRI earlier. Now we know,
Yeah.
is that taken before or during the procedure?
Yes. Usually that is taken before. That is taken before and that is what we use for planning to draw out the lesion. And basically after we do the MRI, we go to a computer station and we draw the lesion, which is what should be hit by the radiation, and the critical structures like the eyes, the nerve for the eyes, and certain areas of the brain that should not be hit. So you more or less tell the computer what you should hit and what you should not. And then from there, it usually creates a plan, and it is up to you to fine-tune that plan. And then from there, that plan is uploaded to the computer, and then our linear accelerator has an onboard CT scan. So when you're on the machine, the first thing that it does is to do a scan on you just to confirm that everything is in place before the actual treatment is done.
Okay, so doctor, let's say I'm a patient coming to you. I get I understand what you told me. Okay, so some of the things, just to make it clearer for people like me and people, well, I hope I don't have to get it at any time, but I would love to meet you in person and talk about things anyway. But let's say there are people out there listening right now, especially if they're here in the Philippines or they're abroad and they're thinking of coming home to get surgery. And this happens to, or they've heard of it before, and this happens to, to match up. I mean, this type of surgery can be used to treat what they have. So first you would get an MRI. How soon before the surgery would you need the MRI? I mean, does it have to be right there and then, or because something may have changed, or a couple of days before? Because that's your
So
tool to map it out, no?
yeah,
Okay.
so we usually do the MRI around 3 to 5 days prior to the treatment. After the MRI is done, that's also the time where we fit the bite block and the mask, so that
Okay.
everything will be ready. So usually the plan takes around 3 to 5 days to create. Let's
Mhm.
put it at 3 days. So let's say we do the MRI on a Monday. We
Mhm.
do the MRI on a Monday. Maybe by Thursday we'll do the treatment. The mask and everything will be ready. You come in to Makati, we'll treat you.
Mhm.
After an hour, you go home. That's
Mhm.
it.
Okay, so that's okay. So that's great. It's also fast, the preparation for it. Okay, so you go in, you get an MRI, and you don't need to fast or anything for this MRI, right?
Well, there is because they're going to give contrast. So
Okay, the
there's
dye.
usually a short fast. Not really a fast like 8 hours. They just make sure that your tummy is not full, because you're lying flat in that machine for around 45 minutes.
Yes.
So it can be uncomfortable when your tummy is,
Been
you
there,
just
done
had a
that.
heavy breakfast, and
Been there,
yeah,
didn't want to do that. But even if
yeah,
okay, uh, when even if you just move a little to, let's say, I forgot how to say fart in medical terms, but it's
yeah,
anyway, let's say you let out gas. You will already hear the technician tell you, "Ma'am, wag kang gumalaw."
yeah,
So yes, okay. So you fast a little, just enough, so maybe a few hours, so that your
yeah.
stomach is full, and they will insert, as you said, contrast. That means you will have an IV with a dye in it.
Correct. And IV access.
What is the dye usually made of?
Um, well, nowadays, it's um, it's a
Sorry.
long name, but
Yes.
GDTPA. So it's a non-ionic contrast. It's not. It's hypoallergenic. But one thing is that it is usually excreted out of the body by the kidneys. So
Okay.
one prerequisite before we do the MRI with contrast is we check your kidney function. So we request a creatinine test.
Okay.
If your creatinine is abnormal, then we need a nephrologist to make sure that your kidneys are ready for the contrast. Because if your kidney already has some damage, and we give you the contrast, then it can actually worsen the kidney damage. So it is standard that we always do a creatinine test before the MRI or even the CT scan, before we give contrast. If for some reason we can't do contrast, then sometimes we will agree to doing it without contrast.
Mhm.
But there are certain parameters that need to be added for us
Mhm.
to be able to delineate the tumor very, very well. But
Okay.
this is more an exception rather than the rule. We still prefer having a contrast MRI done.
Okay. So as you mentioned, doctor, just to recap, um, getting you do need, okay, you do need an MRI. This is done 3 to 5 days before the surgery. I guess also, so that it you you do need an MRI with contrast. That means there's a dye going into your body, and you have to fast a little bit for that, as long as your stomach isn't full. And I'm
Yeah,
sure, if I'm sure you prep your patients by telling them beforehand. And just in case, it's an exception, not a rule. But I'm sorry, it's a risk if your kidneys are not great, because the dye is excreted, so your kidneys get rid of it, and that dye in particular can lower your kidney function. But you take a precaution. So I guess that's one of the risks, but you avoid it already for all patients because you also order a creatinine test, which is simple blood test. Yes.
Yeah.
No need
Yes.
to fast for that. Do you also order an GFR, an EGFR, or just a
No,
creatinine
usually.
test?
Usually
No.
not. Another, I forgot to say that for the planning MRI, it has to be done here because sometimes, patients come from somewhere else, they already have an MRI, and they say, why do I need another MRI?
Mm.
Because the MRI that we're going to do here is very fine. It's, like I said, an ordinary MRI will have around 5 millimeters cut.
Mhm.
Here is going to be a 1 millimeter cut because that is what the procedure requires. It has to be millimeter accurate. So your data or your MRI also has to be millimeter cuts for it
But
to be accurate. And usually the data is directly passed on from the MRI machine to the planning computer, so that there is no loss. It's
Mhm.
not placed in a CD or in plates or anything. It is
Yes.
directly beamed to or transferred to the computer, so there is no loss.
That's I'm so happy you mentioned that, doctor, because yeah, a lot of people come in and say, but I just got my MRI somewhere else because I found it more convenient or cheaper or whatever it is. But as you said, you need it down to the millimeter. And when we talk about loss, I guess it's you talk about resolution, no? For like cameras or I don't know, pixels, computers. As you can tell, I'm not really a techie when I say these things, but if you transfer it onto a CD or something, there's kind of a loss of resolution, I guess. And, other labs will not know exactly what you're getting the MRI for. So they won't, make it, there's already kind of like a loss, like it's a copy of a copy. But in Makati Med, directly from the MRI that you take, it's beamed to the computer that you use after you take after you take the MRI. It's beamed to the computer that you use, that you use, Doctor Zablan, that neurosurgeons like, sorry, Zabalza. So that neurosurgeons like yourself use, to do the actual operation. And okay, let's say, okay, just a scenario. No, what if somebody has steel implants in their body? Can you still do the MRI on the brain or the spine?
Still no, but well, usually after 1995, most implants are already titanium. So we just have to check if what the composition of the implant is. Actually, there is a gadget wherein they can check um,
Mm-hmm.
uh,
Can check.
the MRI is only sensitive to what we call ferromagnetic metals, so steel, iron. So anything other than that is okay. Usually we use titanium in most implants in our body. So even if there are implants, so long as it's made of titanium, then
Mhm.
it can be done. Uh, braces is a problem.
Yes, when you
So
have braces in your
yes, so
mouth. Yeah.
braces. So
Yeah.
if a patient has to undergo stereotactic radiosurgery and they have braces, we ask them to have it taken out.
Yes. I'm sure
Yeah.
for a while they're relieved there. I mean, like,
Yes.
know.
Yeah. So the braces will create a lot of artifacts, and
Mhm.
it will lead to inaccuracy. So we ask the patients to have their braces taken out just for the procedure.
The reason why I asked, not that this scenario is there for the a person that I know to have stereotactic radiosurgery. Thank God the need is not there. It's just that I know someone, she broke her leg, her femur, and then a titanium implant was placed, but the implant broke. So
Okay.
yes, the titanium implant broke, so they replaced it with steel, and that's the reason why I asked, because she's always careful about getting MRIs and the
Yeah.
other choices usually to get a CT scan. But as you said, there are ways that you will work around it if there is a special case, and the
Yes.
person is the person who has this condition or lesion in whatever part of the body that you can use stereotactic radio surgery on, or SRS. You will find the safest possible way to do it. And in terms of the kidneys and using the contrast dye, I just wanted to mention one more thing. You mentioned that it's hypoallergenic. I'm
Yes.
glad to hear that because before they used to use a lot of like shellfish, no, for the
Mm.
coloring or whatever it was, and people would get scared sometimes because they'd be allergic to the dye actually, and then you'd have to treat them right there and then and inject them with an antihistamine or steroids. But now the dye is pretty much hypoallergenic. You do take the creatinine test beforehand. So these are some of the ways that you prepare for the surgery. And on the day that they get their MRI, that's 3 to 5 days before, you usually have the mask done already on the same day.
Yes. Usually when they come in for the MRI, we usually also ask them to pass by the radiotherapy area so that the bite block and the mask can be fitted.
Okay, so that's great. These are some of the tools you use, no, for this technique. Some of the equipment that you use. The MRI. I mean, that's you lie there, assuming there are no other complications or things you have to consider. You check it out with the patient anyway. They lie there, they get the MRI, and then you get your bite block, and your mask and the thing for your nose bridge to hold your head still fitted. It's made specifically for you. It's not one size fits all. And that's really important because we don't all have the same, obviously our teeth, and stuff. We don't have the same size of jaw, mouth, our features. Okay, so to be able to hold it still during the surgery. So once the patient comes in for surgery, what happens? Like, are they lying down? Of course, face up. My face down ba? Is there ever any case where
No,
there's
it's always face up.
face up,
It's always
face down
face
is
up.
a lot. Yeah, face up, and then you put the mask on, and you have their information from the MRI. As you, sorry, you planned in those 3 days. It takes about 3 days to make a plan, as you said. You input it in the computer, but it's up to a neurosurgeon like yourself to to fine tune it, as you put it, to fine tune the plan for the surgery and say, okay, this is the part that you really need to get to. And then, this is how much you will calculate also with the help of technology, the dosage of radiation that the person needs to get in for that particular thing, the size and all of that. And then when they're there on the table, when the patient is on the table and you have this, where's that plan from the computer? Is there a computer right beside you? Use a computer as your operator?
Yes. The plan is actually uploaded into the treatment computer, and that's the thing that controls the movement of the table, the when the radiation is on, how much radiation will be given. Yeah, it's a complicated thing.
Yeah, no, but at
But
least
just trust us.
yes, no, that's why we trust human beings like yourself. We can't just trust a computer, but these are tools that you use to help you,
Yes.
and to help you treat patients and not cut into them necessarily. No, it's always safer that way. I guess. Yes, it's always safer that way. Because once you cut, of course, there's a risk of infection. No, and okay. So do you need to shave your head? Let's say it's the
No,
brain. No.
no,
Okay. So do you anesthetize the person?
no.
Anesthesia? No. What if the person's very nervous? And
They're usually not.
okay, they're usually
No,
not.
because unlike an MRI wherein you
Yeah.
go into a tube,
Yeah, I
here
think
it's open. It's open. It's open. There's a big machine in the room, but it's not claustrophobic.
yes, it's not
Yeah,
claustrophobic.
it's an open machine, and but unlike a scan or an MRI where when you're nervous you can have somebody go inside the room and hold your hand.
Yeah.
This you can't do that here because of the dose of the radiation. You'll be alone in that room, but it
Okay.
will only last around 15-20 minutes.
So you'll be alone in that room, but I guess you would have like machinery there pointing to whatever part. And I suppose the mask protects the eyes as well, no? Because we have to protect our eyes. Is
Well,
that a
yeah.
valid
Well, the radiation will
misconception?
never go through the eyes. It
Ah,
will. It is already planned that it will not go through the eyes. the nerve for vision, what we call the brainstem. Those are the areas that are what we call critical structures that cannot be hit by radiation. That is taken into consideration when we create a plan.
Okay, then you as a neurosurgeon will be like, I guess, in a room right beside it, directing it, watching over the patient, and
Yeah.
the radiation hits. So it's actually, you're right. No, MRIs can be claustrophobic because you're in a tube, and then you hear that sound, that
Yeah.
that,
Very noisy.
yeah,
Here
kind.
you can play your favorite music. There's no sound.
So
There's
you
no noise.
allow people to put like to use headphones or
No, you
something.
cannot.
Cannot.
No,
But
they
you
can
can
put a
in the room,
yes.
play it into the room. Okay. So maybe they should. Okay, that's great. Okay, so whatever their favorite music is, you can play it in the room while they're getting the surgery, near the SRS, and it takes about 15 minutes, as you said, because you just
If it's
deliver.
a small lesion, 15 minutes. If it's a bigger lesion, the longest would be around 40 minutes.
So during this procedure, so 15, if it's a bigger, the longest is 40 minutes. And you did mention that it's what do you call this, outpatient procedure. So there's no risk involved, like the patient doesn't need to stay. Anyway, the patient doesn't need to stay and be observed
No,
for.
no, they go home. After the radiation, though, it is expected that the brain will have some degree of swelling because of the amount of radiation that has been delivered. So usually we give them a short course of steroids to address the brain swelling after the surgery. We usually give steroids for around 3 or 5 days, depending on the lesion.
Okay.
But that's about it. Sometimes they may have some headaches after the surgery because of the brain swelling, but usually they complain. They don't complain of anything after the surgery. Sometimes the actual reaction is, yun na yun, tapos na.
That it seems like, I mean, that the tests might even be more stressful than the actual surgery for
Yeah.
patients, but of course it's all, it's all needed to for that. And like other surgeries, like when the patients go home, you said usually the brain will or might swell because of the radiation, so you give steroids, and is that oral?
That's tablet. That's a tablet.
Tablet,
Yeah.
okay, for about 3 to 5 days, usually, you said. And you don't give anything like antibiotics like with other surgeries. No, there's no
No,
risk of infection.
no wound. No wound. So yeah.
No wound, no infection, no risk of bleeding, that type of thing. Okay, great. Okay, so I mean, you've just walked us through how to, in a sense, prepare patients for surgery, like it's 3 to 5 days before, and then if you need to call in a nephrologist, you do. And but those are different scenarios, and they're more the exception than the rule. Also, one thing I was thinking, it like other surgeries, do you tell the patient not to take blood thinners or anything like that? Does that
No.
affect it? No. So just keep taking your meds if you need to, like for your blood pressure, whatever it is, and then it's just pretty much in and out, no, doc? It's pretty
Yeah.
much, yeah, pretty much in and out. Okay, so
Yeah.
doctor, before we talk about this more, and it's such an interesting and sort of like, I don't know why I feel relief for people who are fortunate enough to be candidates for stereotactic radiosurgery as opposed to traditional surgery. I think we just do have to take a short break. So stay tuned. And doctor, stay there. Don't go anywhere. And to the viewers and listeners, stay tuned to DZRJ 810 AM, Radio Bandido. This is Health Time with Makati Med. I'm your host, Nicole Jacinto. And of course, if you're viewing us on YouTube or Facebook, and you can watch it as many times as you want and keep watching it so that you can hear the doctor tell us more, and you can again find the answers to what you want. And by the way, if you have any questions, do text us or message us so that we can ask the doctor while he's still on the air, so your question can be answered. Okay, so doctor, hang in there, and I'd be lost without you. And to the viewers and listeners, stay tuned. We'll be right back.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
Hi, this is Dr. 𝗛𝗶𝘶 from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable at Makati Med Care Access, Araneta City. What's more, Makati Med Care Access is the only single-use hemodialysis center in Araneta City. It's now easier for patients to avail of renal care services right in the heart of Cubao. We offer health screening and diagnostic procedures in this facility at affordable rates. You can get services such as mammogram, ultrasound, lab procedures, ECG, and many others. We believe that access to affordable, quality, and compassionate healthcare is a basic human right. And we at Makati Med Care Access Araneta City are doing our best to make this possible to more people. You can find us at the ground floor of Manhattan Plaza Tower 1 in Araneta Center, Cubao. We are open from Mondays to Saturdays from 7 a.m. to 5 p.m. and Sundays from 7 a.m. to 4 p.m. For inquiries, you may reach out to us at the numbers below. We look forward to serving you here at Makati Med Care Access, Araneta City. This is Dr. 𝗛𝗶𝘶 from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable through Makati Med Care Access at 𝗛𝗶𝘶𝗵𝗹. Available for outpatient care services, our 𝗛𝗶𝘶𝗵𝗹 site offers consultation and diagnostic procedures such as medical assistance, hospital admission assistance, blood pressure monitoring, laboratory tests, and X-ray, among others. This is really convenient for those residing in Makati and nearby areas who do not want to go to the hospital to have these treatments and procedures done. We believe that access to excellent quality and compassionate healthcare is a basic human right, and we at Makati Med 𝗛𝗶𝘵𝗵𝗹 are doing our best to make this possible to more people. We are open from Monday to Saturday at 8 a.m. to 5 p.m. at the third floor of 𝗛𝗶𝘵𝗵𝗹 in Makati City. For inquiries, you may reach us at these numbers. We look forward to serving you here at Makati Med Care Access 𝗛𝗶𝘵𝗵𝗹. Hi, this is Dr. 𝗛𝗶𝘶 from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable via Makati Med Mobile Care Access. As the name suggests, this service is mobile, which means that we go to where you are. Mobile Care Access deploys a team of professionals for face-to-face consultations and to conduct basic laboratory and diagnostic procedures, as well as vaccination and testing, depending on your needs. We can go to any location of your choice within the metro and readily offer these healthcare services to communities or groups. For added convenience, different modes of payment are available, including HMO benefits for those with a valid letter of authorization. We believe that access to affordable, quality, and compassionate healthcare is a basic human right, and we at Makati Med are doing our best to make this possible to more people. For inquiries, scheduling, or pre-registration, you may reach out to us at the following numbers. We look forward to coming to you and serving your community with Makati Med Mobile Care Access.
You're back with Healthline, keeping you healthy. Moderated by Nicole Jacinto.
Hi, everybody. Welcome back to Healthline with Makati Med. I'm your host, Nicole Jacinto, and I'm going to turn the lights on. It's starting to get a little gloomy and rainy out there, but the show is not gloomy at all. We have a great guest today. We have a neurosurgeon with us. We have Dr. Michael Zabalza, and he has been explaining to us what stereotactic radio surgery is all about, or SRS. Actually, kind of like saying the name the long way, doc, because I like the thought of stereos, which people, don't. Before we used to say, "Oh, do you have a stereo?" And then radio. Of course, I love radio, and all of that. So, but okay, to shorten it, we can call it SRS, as he says. And doc, you walked us through the steps that it takes. You've described how it's different from other surgeries, like neurosurgeries. Like, for example, you don't cut. You don't cut in. It takes a very short time to treat that lesion or tumor or whatever it is that you're treating. It's very precise. So you don't, I guess, make a lot of room for allowances. Like with other surgeries where you cut, there's an allowance. You also made it clear that you don't remove. It doesn't remove the whether it's a lesion or a tumor or whatever it is in the body, but it renders it basically dead. So it's there, it's dead. It can't really cause you any harm anymore, but it stays there in that area of whatever part of your body it is. And you did mention that stereotactic radiosurgery, or SRS, can be used as a technique alone to treat lesions or tumors or other conditions or diseases that we have, whether it's the brain and for example the spine. You said it can be used also to when, for example, somebody has a certain kind of kidney cancer and it metastasizes to the spine. It's not that particular kidney cancer or renal cancer. Once it metastasizes to the spine or spreads to the spine, the tumors there they aren't basically killed off by the regular type of radiation. And this is where stereotactic radiosurgery comes in, delivering that one dose that kills the tumors in the spine, so they don't grow anymore. So they don't cause more damage than they already have, or so they don't cause damage at all. Maybe they're small enough to not have caused damage, but you detect them. And you also did say that stereotactic surgery can be used as an adjunct, or something that you use along with a regular type of surgery. You mentioned earlier that, like, one thing now you clarified for us was that if there's, let's say, a big tumor in the brain, since stereotactic radiosurgery doesn't remove the object or the tumor or the growth or whatever it is, it just renders it, I guess I would call it innocuous, no, harmless. Then sometimes it's not ideal for certain types of no, it's not. Yeah, it's not ideal for certain types. Because when tumor is so big, it puts pressure on the brain. But you did say it can be used along with regular surgery. If there's a part of the brain, let's say, where the tumor is located in part of the brain that can be touched, because you said there are times when you just never touch that part of the brain, you never manipulate it, as you put it. So if part of the tumor, like there's a small part that's in an area of the brain where you shouldn't touch with surgery, and the rest of it is an area that you can touch or remove, then you use that. Like, you take out the part of the tumor that can be taken out, and then you use stereotactic radiosurgery to focus in on that part of the tumor that's still left, and you use it to kill it or render it harmless. So these are all very interesting things that we're learning here, Doc, and they're certainly interesting to me. I actually got a question here via text. Can you use stereotactic surgery to treat aortic aneurysm?
No, unfortunately.
And that would be because
Well,
uh,
aortic aneurysms are, it's a structural problem. So it has to be either stented or taken out. I mean, and replaced with a graft. Well, I'm not a thoracic surgeon, so
yes,
I
but still,
wouldn't be the best person. But no, radiation cannot be used to treat that.
it won't. As you said, it doesn't take it out, so it doesn't make it smaller or anything.
Yeah.
Okay, please excuse that. Whoever's calling me, and if you're watching this at the same time, don't call me right now. I'm using my phone for the show. Anyway, um, here's another question I got. How can you tell if a patient can I I guess it can get stereotactic surgery. I guess it's how can you tell if a patient is
Yeah.
a
Okay.
candidate?
Well,
Okay.
by the MRI or any imaging that's done on the patient, we more or less will already have an idea on what it is.
Mm-hmm.
Okay, so if it's one of the lesions that can be treated with stereotactic radiosurgery and it is within the ideal size, I forgot to say,
Mm-hmm.
ideally, the cutoff is 3 by 3 centimeters. The
Mm-hmm.
tumor has to be below 3 by 3 centimeters. If it is above 3 by 3 centimeters, then there is a technique wherein we can divide the dose instead of just one. It can be divided to 2 or 3 doses, but the true stereotactic radiosurgery is one dose only. So if the tumor is amenable to stereotactic radiosurgery and it is below 3 by 3 centimeters, then usually we can treat it. Because the reason for the size is um, the dose is proportionate to the tumor. So if it's a big tumor, then you'll need a higher dose, and there's only a certain amount of radiation that the brain can tolerate. So anything beyond it, it's either you operate and make it smaller so that you can give a higher dose, or you can divide the dose instead of being given for one dose only. Then you can divide it to two to three. The effect is not the same, but still it is still more effective than the old style of giving it for around six weeks or 30 sessions.
Mhm. Okay, so as you said, one of the things that would make, I guess, a patient a candidate for this is if the area you're treating that you need to treat, or the tumor, the lesion, is also small enough. So size matters here.
Yes.
It's also small enough because the true stereotactic radiosurgery is supposed to be delivered in one dose only, and the radiation level is really high. But you did say that some adjustments can be made in terms of, like, okay, you decide with this person, with a patient, that it's a bit bigger than what we would usually do, but you can divide the dose. And the reason for that is, as you said earlier, you can only take, or the brain or the body, the human body can only take um so much radiation at one time, because some people might say, why don't you just up the dosage, no, make it higher, that way you can cover that whole area, or do it. What you said is, no, there's only so much radiation the body can take. But you can, or you have done certain surgeries where there's a scenario where you've delivered a dose to the different part of the tumor. Divided it in 2 sessions, maybe, or
Yes.
um
Um,
deliver.
in tumors called vestibular schwannomas actually come from the nerve
Mhm.
going to the ear, and the tumor is intimately related to the facial nerve, the nerve that allows us to move half of our face.
Okay.
Usually, if the vestibular schwannoma or the tumor is a bit big, what we do is knowing that the facial nerve is intimately related to the tumor, sometimes we intentionally, even if the tumor is within radiosurgery size, we will divide it because it results in a lower risk for paralysis of the facial nerve.
Is this
So there are certain situations wherein we will intentionally divide the dose just to make it safer for the patient.
the trigeminal nerve by any chance, or is it a different?
Trigeminal neuralgia can be treated with stereotactic
Can?
radiosurgery.
Okay,
Yes,
I got too
it
excited.
can be. It can be treated with stereotactic radiosurgery. The only difference is that it is not immediate, meaning we treat it now. Usually, the effect might come 2 to 4 weeks later on, but it
Okay.
can be treated non-surgically with stereotactic radiosurgery.
Is it a new discovery? I mean,
No, even
no?
no,
Dang. Since when?
since the 90s.
That trigeminal neuralgia has, I only heard about it or discovered it in like 2015, but has trigeminal neuralgia been something that you've been treating with stereotactic radiosurgery since the 90s, or
Well,
is
stereotactic radiosurgery treating, since we're in the area of trigeminal neuralgia,
yeah, sorry, but
trigeminal neuralgia is initially treated medically. First line of treatment is still medical. If medical treatment is not successful or the patient cannot tolerate the side effects of the medication, then other procedures can be offered. What we call stereotactic radiosurgery is one, then open surgery, microvascular decompression, or RF or radiofrequency rhizotomy can be done. The advantage, of course, microvascular decompression is the permanent solution because the pathology there is there's an artery that's irritating the nerve. So you physically separate the artery and the nerve and put a Teflon spacer so the vessel won't come into contact again with the artery. The other option is stereotactic radiosurgery. So basically, we're going to burn the nerve. So it kind of shocks the nerve. So the pain will go away. But the disadvantage is sometimes the pain will come back.
it will come back.
Because remember, we are not going to burn the nerve, but more or less just to irritate it so that it will it will reset itself.
Okay. So
Okay,
yeah,
so
you're resetting it to
that
not.
yes, that is one disadvantage of SRS for trigeminal neuralgia.
Is there?
It is non-surgical, yes, but it can recur. So say for an elderly who has so many comorbidities, then we can do stereotactic radiosurgery for trigeminal neuralgia because it is a non-invasive procedure. It's an outpatient thing, no risk, no anything. The other thing is radiofrequency rhizotomy. So there's a needle that's inserted into the cheek, into the nerve, and the nerve is heated. The same thing, the nerve is heated. It kind of injures the nerve and resets it. And the nice thing with radiofrequency rhizotomy is there's an immediate relief in pain. But again, the pain can come back.
Okay, yes. There's always a risk of it coming back, but at least for that time, you're not experiencing the pain, and who knows, it might not come back. And as you,
Yes.
when it comes to trigeminal neuralgia, and for those who don't know about it, I guess just briefly. Well, you are a neurosurgeon, doctor. Maybe you can just tell us briefly what trigeminal neuralgia is, instead of me being the one. Yes.
Okay. Trigeminal neuralgia, well, it's the French term. It is used to be called tic douloureux or painful tic. So it comes from the irritation of the trigeminal nerve. The trigeminal nerve is the nerve that absorbs sensation on the half of the face. And because of the irritation, you will feel electric shock-like pains on your face. And it's very painful. Some people during the older years, people actually kill themselves because they don't know, the pain is so severe that there was no medications back then.
No painkillers.
So
Yeah.
Yeah. So nowadays there are some medications for it, but most of the medications just designed to soothe the nerve from the irritation of the blood vessel that is in contact with the nerve. So later, the surgery was devised to what we call microvascular decompression. So the nerve and the vessels are physically separated, and some padding material. Nowadays, it's Teflon that's placed in between the artery and the nerve to prevent it from coming into contact. That is the permanent solution to it.
Thank you, doctor. Thank you for educating us on another matter, which is trigeminal neuralgia. And by the way, can I get your number later? I may
Oh,
have
sure.
okay, okay. We have a patient for you. That's why I'm asking for it. So, doctors, whoever likes doctor and is having and has a crush on him, don't get mad at me. I'm not your competition. Okay, it's for medical purposes. Okay, okay. So, doctor, thank you for that information. Thank you for answering the questions that we received. Earlier we were talking about what recovery is like for a patient, no, after they get surgery, they get SRS or stereotactic radiosurgery, and you we were talking about how it's almost like they're in and out. It takes 15 to 40 minutes at longest, and but what are there specific precautions or steps that a patient should take
Not really.
recovery process,
Not
not
really. Not really. So we usually have our first MRI around 6 months after the treatment, so that we can already document if there's already some effect from the radiation. Remember, because we're not actually taking out the tumor,
Mhm.
we're just killing it, and sometimes there is a lag time between the desired effect, which
Mhm.
is to kill the tumor, and some actual shrinkage. Usually it occurs around, the earliest is around 6 months, and sometimes the latest is around 3 years.
Okay.
But the important thing is during that time, the tumor is not growing anymore.
Okay. So once you've done the surgery, no, stereotactic radiosurgery, you're sure that it's already the effects have started taking place on the tumor or whatever it is in that area. So whether it's the brain, the spine, or another organ of the body, how the patients follow up with you, like you said, they don't really have to do anything special, maybe just rest, um take the steroids if you've given them steroids. If they complain of headaches, I'm sure they can consult with you and you can say, take this or take that
Yeah.
and rest some more. um should they be drinking alcohol? No.
No, no relation.
No relation. Okay, I like this stuff.
Yeah,
Yeah, at least you're being honest about it, right? Okay, there's no
yeah,
relation. And I mean,
yeah.
you're
You
not
can
hurting
you
people.
can drink and celebrate right after the treatment.
Yeah. Okay. And then all right. So, there's that, and I'm sure they just keep taking their meds as you said earlier, because like with other surgeries, like you do have to stop taking blood thinners, but with this one you don't have to. So I'm sure after the surgery you can of course keep taking your blood thinners or whatever. If you're on, let's say you're hypertensive and you have that kind of, and you take that kind of medication as the doctor has told you to do so. And then as for the follow up, you mentioned, do they don't have to come back and check only about the early, you said that since you're killing it and not removing it, it takes some time for it to show. It dies a bit slowly in a way. Um I guess that's a most simple way for me to understand it and say it. It takes longer to die, but it's already dying. Like it's irreversible. The tumor will die, but it's dying. It's still dying. Do they have to? You said the earliest is about 3 months to get another MRI, but in
Usually 6. Me, I usually have
uh,
my first at 6. So after the treatment, I usually see them in the clinic a week after the treatment. If
okay.
everything is okay, then the next time I see them would be 6 months after.
Okay, next time is 6 months after. And then you said sometimes the patients have to keep going like aftercare. and getting their an MRI or whatever it is you test you prescribe them to take a look at that area, up to 3 years, for up to 3 years, you said the
There are
longest.
some that will take that long.
Mhm. But at least it's dying.
Yes.
Irreversibly, you won the battle. Okay. Well, doctor, I think we are running out of time. I've enjoyed this conversation so much with you. You've told us how you monitor patients after to know whether the procedure is successful, and that's through, like, you see them a week after. If everything is okay, then it's 6 months at the earliest, and then sometimes it does take up to 3 years, but that's the longest. And is there anything you'd like to say about any new developments in stereotactic surgery, radiosurgery, or anything about your clinic perhaps, or your practice, or you just want to say hi to someone out there?
All right. I'm a very private person. I just
Okay.
like working. You know.
Yeah.
But
Okay.
yeah, don't. I think it's important for you to trust your doctor.
Mhm.
We're here to help. I think that's my
Yes.
message.
Yes. And of course, patients also have a choice to find a doctor that they really trust, then, if and as you said, if you trust your doctor, then trust your doctor, because you're there to help. And you are the type of doctor, I guess, who is the yes, you are the type of you're in essence, by saying that, you're saying you're the type of doctor who's there to help. That's your agenda, to help the patient. Thank you
Yes.
very much for being on the show today.
Okay.
Thank you for joining us, everybody. This is Healthline with Makati Med. I'm your host, Nicole Jacinto. We have been talking about SRS, or stereotactic radiosurgery, with Dr. Dr. Michael Zabalsa. Thank you very much for being on the program, doctor, and we hope to have you again soon. And we'll have you back over and over again for all the types of neurosurgeries that you do.
Okay.
You make such great analogies, and you explain so much to us. It's been very educational for me. Thank you, doctor.
Okay. Thank you.
Thank you.
Thank
Bye
you.
bye.
Thank you for tuning in to Healthline with expert doctors from Makati Med, giving you the chance to interact, uplifting your lifestyle. Moderated by Nicole Jacinto. Tune in again next week for your weekly dose of Healthline.
The views and